Hello, and welcome to the Duke Cardiovascular Imaging Conference. I'm Manesh Patel, Assistant Professor of Medicine in the Division of Cardiology at Duke University Medical Center. Today's program is titled Imaging in Congestive Heart Failure, and our distinguished guests are Adrian Hernandez, Associate Professor in the Division of Cardiology, and Zubin Eapen, a Fellow in the Division of Cardiovascular Medicine. Both are colleagues of mine here at Duke University Medical Center. Adrian and Zubin, thanks so much for joining us.
Thanks for having us.
Thank you.
Great. Well, we were hoping to have Zubin present us a case on a patient with heart failure, talk about some of the imaging issues, and then sort of ask you guys how we manage them and how we take care of patients and how imaging plays a role. So Zubin, you mind starting us off with a case?
No problem. Manesh, thank you for this opportunity. I recently had the chance to participate in the care of a sick patient who fortunately did well. But I thought this was a case that was illustrative of the many different imaging modalities that we could use to take care of a patient with congestive heart failure, particularly when it intersects with other problems such as coronary artery disease. This is the case of a 54-year-old male with left scapular pain and shortness of breath on the evening of admission. He actually had these symptoms that were occurring intermittently for approximately 2 months, worse with exertion, and each episode would last approximately 30 minutes and improve with rest. He really didn't have much of a past medical history, and a lot of this was probably due to the fact that he had not sought out care in the past. No allergies, no medications. He did note a family history of multiple relatives with premature coronary disease. And also his social history was notable for the fact that he was an active smoker, smoking about a pack a day for about the last 40 years, but did deny alcohol and illicit drug use such as cocaine. His physical exam was largely remarkable for the fact that he appeared volume overloaded and that he was in heart failure. His heart rate was 89, his blood pressure was 140/80, but he appeared to be in mild discomfort, mostly because of shortness of breath as well as some chest pain. He did have some jugular venous distension. There were scattered routes throughout on his lung exam. His cardiovascular exam was notable for a regular rate and rhythm, as well as a mitral regurgitation, which was appreciated. And his extremities did reveal pitting edema to the pretibial area bilaterally. His ECG was largely unremarkable as far as STT abnormalities go. He was in normal sinus rhythm, and he had mild left ventricular hypertrophy. And his laboratory data was mostly notable for the fact that he had negative serial cardiac biomarkers and that he had normal renal function. Here's his chest radiograph, which shows obvious interstitial edema and goes well with his physical exam for the fact that he was in heart failure. There were signs of pulmonary venous hypertension, as well as the fact that there was a loss of the AP window, showing that this probably is cardiogenic pulmonary edema. So our impression initially was that he was in acute decompensated heart failure. He might have an acute coronary syndrome. And we have done a good job to this point of doing the history and the physical, certainly guideline-driven care for possibly diagnosing heart failure. And then the question arises, what to do next for a patient that may have multiple problems like this?
It's a great introduction, Zubin. And I might say that, as we think about our heart failure patients, and Adrian reminds me of this all the time, that they're often very sick with multiple medical morbidities. This patient at least seems to be driven by cardiovascular complaints on presentation, not a lot of other comorbidities. And is presenting with acute decompensated heart failure. Adrian, what are we supposed to do with these patients when they first come in with acute decompensated heart failure? I know you've just done a large clinical trial. What do we know about this prognosis for this 54-year-old gentleman?
Yeah, so at the beginning, the prognosis is actually pretty poor. So they have a high risk of in-hospital mortality rate. Their 30-day outcomes are also poor, and at least among Medicare patients, the rates of mortality or readmission are over 25%. So really, there's a focus in terms of treating their acute decompensation, but also, especially in this case where they haven't really been diagnosed before, we need to plan for the future and do long-term risk stratification. What are the therapies that can improve their long-term outcomes? And so there's a lot of investigation that needs to be done at this point.
That's a great leeway into sort of what are we going to be doing, but I guess one of the things that struck me as you were speaking was that this is a combination. It's a new potential diagnosis of heart failure and a person that's got acute decompensated heart failure. So we're going to sort of be having two things we're trying to do. So what did you guys do? He said investigations. What investigations were you guys thinking about doing?
So there were several imaging modalities that were used for this patient. And certainly there are many imaging modalities that can be used, and there are guidelines that are around some of these imaging modalities. Echocardiography, obviously the workhorse of imaging in heart failure, has class 1 recommendation for de novo diagnoses of heart failure. And it can be used to assess many different things, not just ejection fraction, but also ventricular volumes, the size, the thickness of the walls, and give us a lot of important information.
So, I'm on a lot of these sort of care patterns where we see the use of different modalities. For acute heart failure, it seems like almost every patient's going to get a chest x-ray and an echocardiogram. What are the key pieces, Adrian, that I want to know from that echocardiogram that's going to risk stratify this patient for me and what I'm caring
Yeah,
for?
so not only the key pieces for risk stratification, but also the key pieces for identifying what therapies they should get. So just a basic function of what's their ejection fraction. So that's a really important piece of information that's going to really guide their care, not only during the in-hospital stay, but long term. But there are other things that can be learned from the echo. So in terms of valvular disease, do they have much regurgitation? What's the severity of that? Also, what their diastolic function is and whether that could play a role here as well. And those are all prognostically important. And then also you can get an understanding of perhaps how long their heart failure has gone on in terms of, do they have marked LV dilatation? Do they have left atrial enlargement? Do they have other features that are going to complicate their care in terms of RV dysfunction or evidence of pulmonary hypertension? In this case, this patient had smoking history, and so that can have an impact in terms of how they're feeling. Also can be important in understanding some of their symptoms as well.
As I suspect we're going to see the echocardiogram, but as I heard the case, Zubin, I was thinking acute coronary syndrome and then maybe complicated by heart failure.
Right.
But as we hear about it more, maybe this person's been having heart failure for a while and now is getting tipped over into worsening heart failure that we are assuming might be ischemic, but we don't know yet. So let's take a look at the echo if you have it and see what you guys surmised on this patient.
One thing I wanted to also have your insight on was the fact that the ACC and AHA, as well as the Physician Consortium for Performance Improvement, is looking at left ventricular function assessment as a possible performance measure. And was interested in your thoughts on echo as well as other imaging modalities being a means of helping to diagnose and treat patients.
It's interesting, and we'll have a conversation here that sounds good. Performance measures, to me, traditionally have been things that we have to do. If we don't do, patients will do worse.
Right.
Examples in the care of patients we often see here, if we don't give an aspirin at them of an acute MI, we know they're missing a benefit. If we don't give an ACE inhibitor to a patient with heart failure and depressed ventricular function, we're missing an opportunity. Is an echocardiogram really there, Adrian? Do we have to do an echo as a performance measure? And if we are we going to pay less to doctors who might be going straight to one test instead of doing an echo and a cath?
It's a good question. So if you think about it in the most simple way, we do that to a degree in terms of patients who come in with heart failure to understand what their ejection fraction is. But that can be information that's done before a hospitalization. So in a way, it's important because it does translate in terms of identifying those patients at risk, those patients who have indications for certain therapies. But I think here, like in terms of having expansion of that, it's still really a hotly debated question. Is should that be expanded, and should physicians be rewarded for such care? And right now, it's not really clear how important this would be in terms of improving outcomes. So that's something that still needs to be investigated.
Yeah, I think so. And as I think about imaging or just procedures in cardiovascular medicine, outside of taking a patient quickly to the cath lab with ST elevation in mind, I can't think of another procedure that's often talked about as a performance measure.
Yeah, and actually on the flip side, you can imagine measures of, say, inappropriate use. So in terms of frequency of imaging and so forth.
Yeah, this is his initial presentation. We could talk about repeat imaging and repeat presentations. So, I think most people caring for this patient would probably get an echo on presentation. I heard his renal function's okay, so if his renal function is abnormal, it'd even drive me more to get an echo because I want to do a non-invasive way that's not going to expose him to the ventriculography at catheterization that I'm assuming he's going to, but maybe we'll talk about whether or not he needs to actually have that.
Right. Well, so Manesh, you wanted to see the echocardiogram.
Yeah.
Here was the initial transthoracic echocardiogram. Here are some selected peristernal long and short axes windows of this patient, obviously showing severe left ventricular systolic dysfunction. And of note, the territorial wall motion or abnormalities, particularly with attention to the inferior wall, which in the short axis looks almost akinetic, was of concern to the primary team.
So how do you guys think about, so I'll go into a little bit of the echo literature that the imagers speak about, so biventricular failure versus univentricular failure. So if both chambers are dilated, is it more likely to be non-ischemic than one chamber? What about wall motion abnormality? Does that make me more likely to think it's ischemic, or how about non-ischemics? Is there good data, or how do you think about your patients when you're caring for them and you see both dilated chambers or wall motion abnormalities. Adrian?
Right. So while that can be suggestive, it's not perfect, and
Yeah.
I think that's the challenge here is that in terms of trying to understand, really what the etiology of it, it does take the constellation of everything. So not only the kind of risk factors or history of their presenting illness, what the imaging shows. So some of these things kind of add up in terms of someone who sounds like they're going to be more ischemic, and at least some of the prior studies suggest that it's consistent. So in those patients who have really severe biventricular failure, that, and it's global, that is suggestive of a non-ischemic etiology, but they could also have chronic coronary disease that's very severe, that's global in territory, and has not been discovered yet, and that can look the same as someone who has a non-ischemic dilated cardiomyopathy. And so I think that's the challenge here, and so you can't just rely on one single test as to evaluate the etiology here.
Yeah, I'll say in our MRI lab, we did a sort of a cohort study that I think some of our fellows have shown that, it doesn't quite hold, like you said. It's about 70% sensitive and specific for both ventricles or wall motion abnormalities. One of the biggest drivers is if they had a left bundle, it seems to really affect wall motion, so it'd be hard for us to hear. So you guys now have a patient with heart failure, chest pain, and reduced ejection fraction with an EF that looks like it's in the 40-ish range and an inferior wall motion abnormality. What are we going to do next? What are you going to give them therapeutically to make them feel better, maybe help them live longer, but make them feel better immediately? And then what more do we need to do to make sure that we understand the patient's conditions?
Yeah, so certainly treating him early on to improve his congestion, improve his symptoms is important. And then also adding the therapies that will help in terms of prognosis and ACE inhibitor and beta blocker and so forth. But I think there's still, given that we have a patient who's had chest pains, had frequent chest pain before coming in, or something that can be equivalent to that, and has this ejection fraction and wall motion abnormality, it's certainly reasonable to further investigate for coronary artery disease. And there are multiple modalities to do that and different standards.
And what would you guys do? I mean, what's the practice here at Duke, and then what's the evidence for the practice? I mean, I could, at this point, I guess, do a stress nuclear study. I could do a stress echo. I just did a resting echo. I'm not sure the patient can move, exercise, but I guess you could give pharmacologic. Some people would argue going to heart catheterization. We are fairly robust with cardiac MRI. Not every center is. How do you decide? There's a menu of tests we could do.
Well, I can tell you what this team decided on was, given the symptomatology and the fact that there was a territorial wall motion abnormality, they decided to proceed straight to heart catheterization in this instance. And, there are certainly guidelines for this, level 2A for coronary arteriography for patients with heart failure who have chest pain that may or may not be of cardiac origin and have not had their coronary anatomy evaluated before. And this patient seemed to fall into this category somewhat. And so here are the angiograms.
Before we look at this angiogram, Adrian, I note on that guideline it's 2A, but it's level of evidence C. It's consensus. It's opinion. And so the guideline committee had the opinion that they should go to cath if they have chest pain. I'm not saying it's the wrong opinion. I think it's probably the right one. But how is it that we got this far in heart failure care and we don't have any studies telling us whether or not they need a heart cath in a pretty common situation?
Yeah, so that's kind of a sad state of affairs, isn't it?
Yeah.
So it's actually kind of an example of the whole world of diagnostic testing that we don't necessarily have the strong evidence base yet in terms of guide testing, in terms of when, how, and who to do it in. While we have certainly evidence in terms of tests and how they perform in terms of sensitivity and specificity, but we don't really have the great evidence in terms before that. And so right now you're working on a trial to help guide that and other areas, and we need that same example.
It's interesting. Yeah, you mentioned this PROMISE trial we're working on for chest pain evaluation. We specifically exclude heart failure patients because it gets confusing.
See, you're not helping us.
We
had a chance and we didn't get any help.
Yeah.
So.
Well,
PROMISE 2. Yeah,
PROMISE 2. Maybe
there you go.
Well, tell us what you guys did here. You did a heart catheterization. I'll tell you what I see, and you can tell me.
Absolutely.
I see that they're injecting the left coronary system, and the LAD, at least midway down the vessel, has got 100% occlusion with a fairly robust collateral coming some from the left side. But more concerning is that there's also collateralization going to the right coronary on this image. So just in this image, if I was taking the picture, I'd be concerned that not only do I have one vessel, large vessel territory, but now the right coronary might be affected too.
Well, it's a good anticipation on your part. The right looked like it was chronically occluded, and so they were concerned about maybe an acute occlusion in the left anterior descending artery and then this chronic right. And
I'll tell you, that's a great point, and, now I'm going to give you the imaging interpretation from the guy in the cath lab. I don't know. I agree. I think this one's maybe more chronically occluding. I can tell you it's less favorable than the LAD because the LAD is a large territory and the occlusion seems short. So, at this point, I think, Adrian, what would you say? You have a heart failure patient with 2-vessel coronary disease, both 100% occlusion, mid-LAD that has collaterals. Enzymes were negative on presentation, so unclear the chronicity of these occlusions.
Right. So, and actually, I think the question remains is, does revascularization offer a benefit here? And so, how do you determine that? So, because it would be a different story if this patient's enzymes were positive, and we had some idea in terms of the acuity of here, but here it's really hard to know. So, I think some people would approach this differently. They may approach trying to revascularize the LAD territory. Others may stop and do further testing to look at viability, for instance. And others may actually say, well, this is, appears to be chronic, and they put them on medical therapy. So we still need some answers here.
So it's pretty amazing. We have a fairly common, I think, presentation of a patient, and what I heard you say is that we could try to open the LAD, stop and talk about it, maybe a cabbage, or even use medicine. So even some of the central questions on revascularization for this patient are unclear yet, or at least being investigated in medicine. So what did the team do?
Well, what's interesting is they did all of the above.
Much at Duke, we often get all of the answers, right? We like all the above.
So initially, they tried to intervene upon the LAD, but were unsuccessful in doing this. They could not completely traverse the occlusion. They kept going to a septal perforator, and so they had to abort this attempt at percutaneously intervening on the LAD. And so the next step was to go to option 2, which you both outlined, which was to assess the viability and determine what could be intervened upon from maybe a surgical perspective.
So maybe I'll stop you there. I mean, I think at this point, what the team might have been doing, I'm not sure, you can correct me if I'm wrong, but I don't think I was affiliated with this patient, but I think if you're not sure if the LAD is chronically occluded, you may attempt to try to open it up thinking there's a subacute chronic occlusion, but some in the OAT trial and others would say you shouldn't be considering that unless you know the chronicity of this condition. But the wire sometimes is a way to test it, and they weren't able to open it without going into chronic total occlusion type of care, and maybe that is a good time to stop and say, what is the function? Is it really 45? Is it viable? Now, we'll go into the viability discussion here in a second, but from my perspective, do you ever just use EF as a viability test, Adrian? Look, we got an echo, and the guy's EF was 40. Maybe we need to do a V-gram, I guess, but would you just say, look, wall motion squeezing, the EF's above a certain number, it's viable?
Yeah, so that's interesting. It's hard to always say that that's the case, and so I think having more information actually is helpful here to really understand viability, because we certainly have seen patients who have ejection fractions of 30%, and then we do further study, and there appears to be really substantial infarct and major territories, and so that in a way helps guide major decisions such as bypass, which we can't necessarily take lightly in someone who has heart failure, who has a low ejection fraction.
Sure. All right, so let's see what they did, Zubin.
Sure. So one thing, and you've commented about this, both you and Adrian have, is that detecting myocardial ischemia or heart failure is reasonable. But it's level 2A with B, a level of evidence B. That it's reasonable in patients presenting with heart failure who have known coronary artery disease, and that's for particularly in patients with no angina. And this case is a little bit different because this patient did have chest pain. But what they were, I think, primarily concerned about was, do they just do the lima, or do they also graft with the saphenous vein graft the right coronary system? And so with that akinetic inferior wall that was seen on the echo, do we also graft that, or would that not be a benefit?
So there's some discussion about chest pain or angina. How much are we using that in clinical practice? I know in the guidelines there's an emphasis on, we believe if they're having discomfort in the chest, the muscle must be alive.
Right.
And whether or not that's right, you can give me your experience or maybe some evidence to say, is that the right way to be thinking about these patients?
Yeah, so we'll hopefully have some answers soon with the STITCH trial in terms of looking at patients who have chronic heart failure without symptoms. And so that's kind of the key question, is that in patients who have angina, have coronary disease, and heart failure, the guidelines suggest revascularization is helpful. But in those patients without angina, it's less clear. The STITCH trial is trying to answer that question. In terms of patient profiles, you can imagine all sorts of patient profiles who may have awful coronary disease, have awful ischemia, have viable myocardium, but don't have chest pain because they have diabetes, for instance, or they have anginal equivalents that are unclear. And so I think those are the cases which are really challenging in terms of determining what to do.
Yeah, I think this is a central question in how we care for heart failure patients. Revascularization, yes, no, but then how do you determine which method and is the muscle alive? And so, unfortunately, I think in the STITCH trial there is probably going to be some evidence on viability, but I'm not sure how much there will be, unfortunately.
One thing I wanted to point out, pre-STITCH trial is what may be informing clinical practice right now. This is a meta-analysis from 2002 by Dr. Allman and others, where they pooled over 3,000 patients from 24 studies, and these were looking at viability either via thallium, PET, or dobutamine echo. The ejection fraction was approximately 32% in these patients, and they were followed for 25 months. But what was the outcome of revascularizing viable versus non-viable myocardium in these patients on mortality at 25 months? And their conclusion was that if you revascularize a viable myocardium, that there was a significant benefit versus medical therapy, but that there was not really that much of a difference if there was non-viable myocardium.
Yeah, and Adrian, you've reviewed this literature, and one of the things I always run into is how do we determine viability?
Absolutely.
That's one important question. The second is, in practice and in these studies, there's sort of an inherent bias of the people that get the revascularization versus those that don't, whether or not the test showed it. So just the act of sending someone to a viability test probably puts a patient at a higher risk category than me not sending someone to that. What are your thoughts about who are you testing? Because if you believe it's alive, you may not do a test at all and just send them for a bypass.
No, I think that's exactly the challenge here, is that times have changed, and also like the selection of patients continuing studies are important. So just here in this example, the techniques for viability have improved since this study was done. If you believe in that concept, there's still questions about that. But then even doing kind of the large trials to try to assess that take many years, and during that time frame, the technology is also improving. And so when you have an answer for a large trial like STITCH, which has some imaging component, but not necessarily some of the viability that we're doing here, we're still left with other questions.
Yeah, and I think at least in viability, there are now starting to be some randomized trials. Rob Beanland's in Canada, and others are doing directed care with usual revascularization versus randomizing to a viability-directed revascularization. I think those are going to inform our practice because it's a strategy rather than the technology.
So this team chose to go with a resting nuclear study simply to assess the viability. And there was some important information perhaps from this, that they saw that the anterior wall was viable, but that the inferior wall appeared cold, and that there was infarct in the posterior basal and the inferior walls. So their question after this was, should we just really revascularize the anterior wall, or should we really revascularize the inferior wall as well? And that was a question that they still were not sure after this nuclear study. So then they went to an MRI to maybe get some more granular information to perhaps complement the nuclear study. But of note, we're now at 4 imaging modalities to take care of this patient with heart failure and potentially coronary disease.
Yeah, I was going to mention that, in an interesting way, this happens in our heart failure patients, but the patient got an echo, a chest x-ray, a cath, a V-gram at a cath, probably, and now a nuclear and an MRI. So at this point, we should know everything about their heart. And looking at these pictures, I guess, when I look at this, without looking at the delayed enhancement pictures, I would say, first of all, viability it's not a yes-no often, isn't it? It's sort of a gradation. The team's trying to sort out what are the probabilities of success with revascularization. But what do you think of that ventriculography? I mean, the cine function left ventricle seems pretty good, not too bad.
Yeah, so I think an interesting comment here is that, probably having that kind of understanding of, what you're going to target in terms of information from the test, can help. And so, having a nuclear and an MRI test for kind of the same question, it seems like, is not a common thing. So I think, here it's certainly kind of an interesting example of, sometimes tests don't answer every single question for clinicians.
And some people have preferences, and until we have more evidence, I think we're going to have preferences rue the day a little bit more.
Right. So here's some of the delayed hyperenhancement, Manesh, that you were talking about. Here's a series of short axes taken from base to apex, and what it predominantly showed was that there was a largely viable anterior wall, as the nuclear study suggested, and that there was some viability in the inferior wall. There was a rim of viable tissue that was seen, and so that there was about 40% viability in the inferior wall, which may have pushed the team more to revascularizing that inferior wall than they otherwise might have done if it was just a resting nuclear study. Would you agree on that?
What do you think, Adrian? I mean, I guess I would say, just looking at the pictures, that it's transmural in some of the, or near transmural
Right.
in some of them. And what we do in the MRI lab when we're looking at viability is we try to do a segmental analysis and say for the inferior segments, for the total area, some percentage of the wall is infarcted. And from Ray Kim's data and others, that transmurality, as you have it on the slide, the percent of infarct tends to relate to the percent of wall motion recovery. So 50% of the infarct in the wall, 50% chance the wall gets better. 75% infarct, 25% chance the wall gets better. Just a rule of thumb.
I think what you were pointing out beforehand is looking at the wall motion abnormality here. Like you could really see that the anterior walls appear to be okay, and actually the inferior wall was really what's having problems here, and so this really matches up the delayed enhancement. So it is kind of still a question of how much one can recruit from that inferior wall with revascularization.
Yeah, and what do we say to the person who says, look, I have a 54-year-old patient with 2 occluded vessels and an EF of 40. I was going to send him to 2-vessel CABG anyway. You guys at Duke did a nuclear, an MRI, and did we need to do that, or should we have just said, let's go to CABG?
Yeah, so I think that it depends on the scenario. So here there are still questions about the chronicity of the occlusions and whether there was viability or not. So at least the MRI, there was 2 things that happened. One was trying to revascularization percutaneously. That was unsuccessful. But then secondly is to try to assess the anterior wall and see whether it would be worth to go the next step in terms of bypass surgery, as well as to look at the inferior wall. So here, there appears to be some viability to target that, those areas.
I think it's good points. And you also, by the way, exclude things we haven't even talked about here today, which is non-ischemic cardiomyopathy. We saw occluded vessels, but it's certainly possible people have mixed pictures. Sometimes on MRI you see other ditzels and infarcts or things you haven't thought about. So I'm not saying it's not feasible. And then, again, the risk of the patient has to be put into revascularization. So a lot of times viability is used to drive the operators into feeling comfortable and the patient that the risk is going to be worth the benefit that might be downstream.
And you could change a few things about this patient's profile.
Yeah, absolutely.
So make it patient 10 years younger and say, well, is coronary disease really
the cause
here? And so you can see cardiomyopathies, infiltrative cardiac disease that will give you wall motion abnormalities or other things, and you could see the same thing. And so MRI has been helpful in terms of understanding whether there are other causes that we can be surprised from.
Yeah, it's clear and biased, but I think if you're looking at the muscle, it's muscle technology, so it gives you some more information. Sure. So what happened after this viability test? Tell me what they did. I'm interested.
Well, both of you alluded to this, is that there were many stops along this hospital course, but ultimately the destination was what you anticipated, which was that the patient went to surgery. He had 2 vessel CABG. He had a lima to his LAD and a vein graft to his PDA. Luckily did well postoperatively, and I guess most importantly, this patient did well in the long term so far. So when he was last seen in clinic a couple months ago, he was asymptomatic, had New York Heart Association Class 1 symptoms. So luckily this was a good ending for this patient. A lot of attention was paid to his care during his hospital stay and thereafter.
That's great. I mean, I think the patient got a great care from you guys and obviously seems to be doing well from the bypass standpoint. Zubin, let me ask you a question. So how are our fellows now who are thinking about careers in heart failure or other parts of medicine incorporating imaging and training in imaging or understanding what modalities they want to think about as they care for these patients? Are we training multimodality imagers or people who think about the global issues?
No, that's a great question. I think, there certainly has been a proliferation of technology, and with that there's been so many more imaging modalities that we as fellows are being exposed to now as opposed to maybe 40 years ago. And so fellows are really trying to think of whether they need to focus on one or maybe do more of a comprehensive experience. Here at Duke, we certainly have a multimodality imaging training where people get trained in many different modalities. And I think it's going to be very difficult in a lot of ways to figure out what's the right test for the patient, and I know Promise does a good job of trying to answer that question because as we get trained in all these modalities, certainly patients can get exposed to many modalities as this patient did, and some are not without their risks. So it's going to be a challenge for us as we train and become clinicians to figure out how to thoughtfully think about the patient and make decisions not only for the treatments but also the imaging and the diagnostic strategies that we take to get to our final goal.
Yes, obviously you've thought about the question some and thought about how we were training our fellows. I hope that we're adding the value in this clinical care setting to where we think about the science. But Adrian, now, so a leader in heart failure around the world, you just completed one of the largest sort of acute decompensated heart failure trials. There's not the same driver for imaging research in any field in cardiovascular medicine as there is, say, for therapies or things that can potentially go to market and have an effect. So how do we ask the questions for imaging within the context of the other things we're doing to see if these patients do better?
Yeah, so it's actually an interesting point. But there may be changes there. So certainly we're in an environment where people are paying attention to cost. If you look at the perspectives from, say, major payers such as Medicare, imaging is very high on their radar. There are calls now to do analyses or compare effective analyses regarding imaging and imaging modalities. It won't necessarily be the case where fellows could get trained in all four modalities and be able to use all four in every patient. They're going to have to know how to select the right test at the right time for the right patient. Otherwise, there's a risk for not being reimbursed. So right now, there's studies ongoing to look at the role of imaging and prognosis and the use of imaging and variability of that and how that can relate to potentially effectiveness. But those are challenging to do in terms of the methods. So the gold standard, and we'll see if Promise holds up, is to evaluate imaging in a randomized trial. So if that can be done there, then we should be doing it in these cases exactly like this. A patient comes in with new onset heart failure and randomize them to 2 strategies of care or 3 and determine whether something that's high-end, like this one, getting 4 tests, versus something else, getting an echo and clinical judgment.
Yeah. I think you put it well, and I think one of the things we're going to learn along the way here with our Duke Clinical Imaging Series is that I think that mantra, the right test, right patient, right pictures, right read, and right communication is probably going to be what we need to do to keep making our patients do well. So I want to thank both of you for just an outstanding conference. And our guest faculty today have been Adrian Hernandez and Zubin Eapen. And Adrian and Zubin, again, great job. We look forward to more out of both of you regarding research in this area. Until next time, then, from all of us here at Duke, this is Manesh Patel saying thanks for joining us and take care.